Hi there, everyone. My name is Alan Winston, and I'm an HIV clinician at St Mary's Hospital in London and at Imperial College. And today we're talking about telehealth in clinical settings since the advent of the COVID pandemic. So for the purpose of this talk, I'm going to review what did HIV care look like pre-COVID, and then move on to what does HIV care look like now, and what are the implications for people with HIV, and especially older people with HIV, and also think about how clinical research has changed and what is this going to look like with telemedicine and the implications for older people with HIV. So if we think about HIV care prior to the COVID pandemic, we saw all our patients face-to-face, generally at around a 6-monthly period. And that was the minimum. We increased that if it was required. Most individuals had blood testing every 6 months. All patients saw a senior medical doctor at least once a year. And the thing we're really focusing on was this fourth 90. So we have our 390s of people diagnosed with HIV, being on treatment and being virally suppressed. But nowadays, we're really focusing on the quality of life for people with HIV, this fourth 90. And these annual checks for the fourth 90 included screening and managing a host of comorbidities, including mental health, bone health, cardiovascular health, cognitive health, and sexual function and health. If we look at the EACS guidelines, the European AIDS Clinical Society, the comorbidity section is the largest section of these guidelines. And they really focus on this fourth 90, on looking for comorbidities and managing to our best ability non-infectious complications that we sometimes see in people with HIV. Now, when the COVID pandemic hit, many organisations across the world made recommendations on the minimum acceptable care for people with HIV. This included the International AIDS Society, UN AIDS, in the US, the CDC, and the US Department of Health and Human Services, and in Europe, the EACS and many of the national AIDS societies. And the recommendations were all pretty similar: to include continued monitoring, to implement telemedicine if possible, and to ensure adequate drug supply for ongoing antiretroviral drug supply for people with HIV. So what were some of the consequences? Well, here in the UK, as in many countries, we went to 6-monthly video or telephone appointments. And the portal is rather than using Zoom or Teams, it was called Attend Anywhere, where our patients could come into a waiting room, be booked in by reception, and then wait for the healthcare professional to see them. We had a mandate from our hospital to keep outpatient face-to-face visits at less than 10% of all consultations. We went to 12 monthly blood sampling. The majority of our prescriptions were posted or couriered. And another important change was the review was by any member of the team, because especially in the infection specialties, many individuals were deployed and working on the COVID wards. And this took the time an individual was in a hospital setting right down to about 10 minutes per year. Now, there have been some nice reviews on telemedicine over the past few months. And this is one review published recently, which looked at the EACS guidelines and thought which aspects have to be done by face-to-face, but which aspects can be done by telehealth. Now, if we think about the third target, the third 90, so virological and immunological targets, well, they do have to be done by face-to-face blood taking. However, as I mentioned before, in general, this can move to 12 monthly. But for many of the other screening tests, they can be undertaken via a telehealth modality. So questioning on psychological health, sexual and reproductive health, questioning on the presence of comorbidities can all be done via phone or video consultations. Asking questions on cognitive health and depression and concurrent medication use, again, can all be undertaken by telehealth. Now, there are some aspects which we would prefer to do face-to-face, especially some of the more detailed frailty assessments and polypharmacy, the detailed drug reviews. So what does this mean for actual outcomes? Well, we are starting to see some studies which have looked at outcomes for individuals with telemedicine. On the left, there is a Spanish study looking at healthcare outcomes for people with HIV in a large tertiary centre, reporting that there was no difference in virological outcomes. And on the right is a US study reporting patient experience of telemedicine and whether individuals were more or less likely to attend appointments and how they enjoyed the appointments. And you can see on the bottom left which statement fits you best. The majority of a sizable majority of individuals actually did not mind telemedicine. So initial data suggesting to a lot of individuals this is acceptable. We do have to think that when we are looking at this fourth 90, this has major implications for older people with HIV, in whom non-infectious comorbidities are more prevalent. So there's a greater burden in these individuals. We can't always get hospital imaging such as DEXA scanning, and we still don't know whether annual renal monitoring or cardiovascular assessments are adequate. Mental and cognitive health is possible via telemedicine, but we do need to recognise the screening tools are often designed for face-to-face consultations. And we have concerns that people with HIV may be more prone to the mental health conditions that we've seen being exacerbated by COVID. We do need to think about language barriers and cultural challenges with telemedicine because it may not suit all. And for concomitant medication, this is something that we really need to be taking good histories and continue to have good correspondence with other members of other healthcare professionals. Now, a Portuguese study has really recently looked at telemedicine specifically for older people, where this app has been designed where it's easy to use. There's only certain modalities, so people can't make mistakes. And if you look at the usability of this, we can see that the patient acceptability, people who kept using the app, was over 70%. And the general acceptability was very high in this study. Now, what about research implications? So at the start of the first wave of the pandemic, all non-essential, all non-COVID research was halted across the UK. We have seen recently research restarting. This is one very nice study, which was a dietitian intervention study in people with HIV with non-alcoholic fatty liver disease, and individuals were randomised to a standard of care, which was nutritional leaflets, or a telemedicine intervention with a dietitian. And you can see that at 3 months of follow-up, those who were randomised to the telemedicine intervention group had a reduction in weight compared to the standard of care group. Also interesting here, they report the variation in food intake during the COVID-19 pandemic. And you can see that some food types, including alcohol, did increase with the pandemic. So what about some of our experiences? Well, we run the POPPY study, an HIV ageing study, and our Wave 4 visit was halted at the start of the pandemic. And our challenges were that people with HIV were generally not attending the hospital, and we wondered, is it ethical to bring people back in? And these are long visits. They generally take 2 to 3 hours, and some of the study procedures couldn't be undertaken. So a solution that we had was that some of the study procedures could be done remotely, some of the questionnaires, and we've linked the study visits into annual clinical visits where individuals are having their annual bloods. So in summary, many chronic medical conditions, including HIV, the way we are practicing medicine has changed dramatically. COVID has probably sped this up, but telemedicine is here to stay, and the fourth 90 can be met. We do need to consider what this means to vulnerable populations and hard to reach populations. And clinical research has also changed, but there may actually be opportunities here to include more individuals in research studies. Thank you very much for listening, and I look forward to your questions.